So chapter 7, documentation of nursing care. And you're going to need your book to follow along here, because there are lots and lots of good boxes and charts in here that you're going to need to know for your test. So my PowerPoint decides to come up. And yes, if you have not taken exam 1 yet, you will get an opportunity to take that. We just have to wait for ExamSoft to start playing nice again. Okay, I'm going to share my screen. So, documentation in nursing care, okay, chapter 7.
Wait, don't we got an exam next week?
No, you have a quiz next week.
Okay.
All right. So we're going to talk about the purposes of documentation or charting, how important it is for a lot of different reasons. We're going to see how you chart to the nursing process. And what was the nursing process? We talked about that last week.
Assessment.
Yeah.
Diagnose.
Planning.
Yes.
Planning.
Yes.
Implementing and evaluation.
Very good. Yes. So the purposes of documentation. Purpose of documentation gives us a written history of the treatment, the care, and response of the patient while under the care of the healthcare provider. Remember, your patient's chart is a legal document. So this is the history of what you did for this patient. If it was not documented, it was not done. So if you forgot to sign out your meds, you didn't give them. If you don't document on a change in condition, then you didn't see it, okay? So it's very important for you to get that history in the chart, okay? It's also used as a guide for reimbursement. Insurance companies and Medicare and Medicaid come in and look at your documentation and see if you have done everything you were supposed to do to get the money you were supposed to get, okay? It can serve as evidence in court if they decide to bring a lawsuit. And that's usually doesn't happen like immediately, okay? It can be up to 3, 4, 5 years after the fact that somebody can say, oh, well, we need to sue this person now, okay? So you're not going to remember that patient. You're not going to remember all the details. All those details need to be in the chart so that they can see them that you did what you were supposed to do, okay? Shows the use of the nursing process, and it gives us data for quality assurance studies. Okay. So documentation in the nursing process, your written care plan is going to be part of the chart. It's part of the medical record. And a lot of documentation is based on your assessment, your implementation, and your evaluation. So charting is organized by nursing diagnosis or by problem. It could also be organized by who's writing the note, okay? Implementation of each intervention is usually documented on some kind of flow sheet or in the nurse's note, but the like your medication administration record is like a flow sheet to say that you gave your medicine. Treatment administration record is a flow sheet that says you did your treatment. And then if there's something different about giving the medicine, or you need to evaluate the wound and document on it, then you're going to document it in the nurse's notes. Okay. And we do indicate progress towards expected outcomes. in the nurse's note. So if you have a intervention in your care plan that says that your patient will remain continent for, you know, the time they're awake, okay, then you need to document whether they were continent or incontinent in your nurse's note. So we know that the medical record contains the data about the patient's stay in the facility, and only people directly caring for that patient or those involved in research and teaching should have access to the chart. Okay, you can't just pull a chart off the rack on a patient you're not taking care of, because that's a HIPAA invasion of privacy issue. Okay, and we never discuss patient information with anyone not directly involved in the patient's care. So you're not going to talk about your patient in the break room. You're not going to talk about your patient outside of school. Okay, so different types of documentation. You're going to need to know these and what the difference is. So first one is source-oriented or narrative charting. We have problem-oriented medical records, focused charting, charting by exception, computer-assisted charting, and case management. So source-oriented or narrative charting. So in a chart with source-oriented charting, there's a tab for the nurse's note, there's a tab for the physician notes, there's a tab for the therapy notes, there's a tab for nutrition, okay? Everybody has their own section and they document in their own section, okay? So that's what we mean by source-oriented. And then we also call it narrative because you're just telling the story. There's no checklist or anything else, you're just telling the story. It requires documentation of patient care and needs to be in chronological order. So, you know, since you are documenting on this patient, you know, in the shift before you documented on the patient, the shift before that documented on the patient, we can look down the list and see what happened this week or this stay in nursing for this patient. We'd have to look in the physician order notes to see what the doctor had to say, and we'll have to look in the therapy notes to see what the therapists have to say. So the information in chronological order is a big advantage of source-oriented or narrative charting. And it does give you a baseline of the patient's condition for each shift. And it talks about all the aspects of the nursing process. Unfortunately, the disadvantage is it makes it difficult to separate pertinent from irrelevant information. So if I was auditing the chart for falls, I would have to go through weeks of nurses' notes to find the information on the falls, right? Okay. So it makes it difficult to find, you know, pull out pertinent information. It does require a lot of time to chart. If you have more than one patient, it's going to take you, you know, 3 times as longer to chart than it would in another type of charting system. And it keeps other health team members from looking at your notes because they're just focused on their part, their source, their notes. They're not going back and looking through the nursing notes to find out what happened in nursing. All right. So it keeps people from reading other people's notes and working as a team, basically. So here's an example of source-oriented or narrative charting. Okay, it is, you always have a date, you always have a time, and we always recommend the time being in military time. Not always going to see a problem in source-oriented charting, but if it's there, this problem relates to the care plan. And so at 2015, the patient states that they have a throbbing pain at a 7 out of 1 to 10 scale. It started at 2000 when ambulating down the hall. We have vital signs, and that the pain is unrelieved by change in position or rest. Now, you notice that this is not grammatically correct. We're leaving out we're leaving out pronouns, we're leaving out articles. You just need to put down the facts. You don't need to write a novel. You don't need to write complete sentences, okay? At 2020, we gave him a Paradine, 75 milligrams IM in the right upper outer quadrant of the butt, okay? And then at 20:45, we went back in and reevaluated, and they were resting comfortably in bed. States the pain has decreased considerably. So each time you document in narrative charting, you need to document the time. And you just need to keep it to the facts, simple, brief. We don't need fluff in narrative charting. There's enough writing as it is, so. The second type of charting is problem-oriented medical record charting, or POMR, okay? Now this is focusing on the status rather than your nursing care, okay? There are 5 basic parts. There's the database, the problem list, the plan, the progress notes, and the discharge summary, okay? And each of those are described on page 88, major components of the problem-oriented medical record. The advantage is that we're focusing on patient problems. So we're focusing on the nursing diagnoses. We're focusing on what's going on with the patient. And it promotes a problem-solving approach to care because everybody's charting in the same section. We don't have separate sections for them to chart in. Everybody is charting on that problem on the same sheet, okay? It improves continuity of care and communication by keeping relevant data all in one place. It makes it much easier to audit patient records. So if I'm going to look for falls, I'm going to go to the falls page in your problem-oriented medical record, and I can see everything that happened related to that fall. Disadvantage is it is not normally in chronological order. Okay, because one day you may be charting on the fall, another day you're going to be charting on an infection. So you're going to be charting on the appropriate medical record, but it's not necessarily every day we're charting on the same thing. Okay, so it makes it difficult to track patient trends, and the data gets fragmented because there's a lot more flow sheets required. Flow sheets for ADL, flow sheets for ambulation, flow sheets for therapy. There's a lot of different pieces involved. So if we look in our books on page 89, these are example of problem-oriented medical records, okay? The first one being a SOAP note. All right, it's 7/18/18 at 0800. And the problem is number 2, pain in the abdomen. So SOAP, and you can actually write that on the side of the chart, okay? S stands for subjective. What did the patient tell us? Okay. What did they say the problem was? And this is, it's a symptom. Remember, what the patient says is the symptom. It's subjective. O is objective. So it's pale. What you're seeing the patient is pale, diaphoretic, shaky, and splinting their abdomen with their hands. And we have our vital signs. Those are objective data that you are gathering. A is your assessment. So they're obviously having abdominal pain. And P is your plan. What are you doing? You're instituting NPO, you're medicating with IM when order received, and you're notifying the physician. So subjective, objective assessment, and plan is a SOAP note. You can take that even farther with the IE and make it SOAP-y. I being your intervention, we're going to give Tylenol. You turn down the heat, we took the blanket off, changed the gown. And then E is your evaluation. So your temperature is a little bit higher now. Your pulse is lower. Your respirations are about the same. Okay. And then the skin is too cooler to touch. So a SOAP note or a SOAP-y note is a prime example of problem-oriented medical record charting. It's one of those things that you're going to see on exams. You're going to see it in the NCLEX. Okay. What is the objective information, or what is the O information for this note type thing? Okay. Another type of problem-oriented charting is the pie charting. Okay. And this is problem, interventions, and evaluation. So using your nursing process, we're gathering data to identify our problem. We're doing something about the problem, and we're evaluating what we did. So example for the pie, this again is on page 90, okay? So the problem is they have pain related to range of motion exercises of right knee by CPM machine. So the problem we identified. We're going to re-instruct in use of the PCA pump and measures for distraction. So our problem is that they're having pain because they're not using the PCA pump properly. Interventions would be your instructions for use of the PCA and encouraged to watch TV movie for distraction. We did check the knee on the CPM machine and it's functioning at ordered settings. We repositioned for comfort. And then we go back in and evaluate them and we say, yes, the PCA was used as needed, the pain's decreased, and the patient states is tolerable. So you notice there's only one time here. Okay. You do all your documentation at one time using the PI, process. If you notice with your SOAP note, the SOAP is all one time, but the SOAP-B notes, your interventions and your evaluations are timed at a different time. Okay, so let's look at, this is actually leading into the next part. But Monica, a nurse in the operating room, then said charting must be all the following except.
Is it 4?
No, it should be complete.
Brief.
No, we want it brief. We don't want to write novels. You're looking at subjective being what the patient says, but this subjective actually means the nurse's thoughts. Okay, so you can't put in your opinion into your charting. You know, you can't say things like the patient is a pain in the patooey. You can't say that the patient is whiny. You can't say the family's crazy. Those are subjective things, right? So we got to keep that subjectiveness out of our charting. It should be accurate, brief, and complete. Okay. So a couple more ways we can chart. We can chart with a focused assessment, focused charting. It's directed at your specific patient problem, concern, signs of thing. So your components of focused charting, we're going to gather our data, we're going to do something about it, and we're going to check the response. So DAR or DAE, both the same, data, action, and evaluation. The advantage is it's compatible with the nursing process and it shortens charting time, okay? But there's lots of flow sheets and checklists. But if we don't have a sufficient database, which we get through our assessments, the patient problems could be missed. And it's not adhering to charting with focus on nursing diagnosis and expected outcomes because it doesn't tell us what the plan is. It doesn't tell us what our goal is. Here's an example. You have impaired skin integrity on the right ankle is our problem. So we have some drainage on the dressing. Okay, that's our data. No order. Hurts slightly. Our action was we cleaned it and put a dressing on it. And our response is that the wound is clean and minimal drainage. And then this one, charting by exception. If you work in long-term care, this is probably how you're going to chart. All right. This is based on the assumption that everything is within standards of practice. Everything is normal and carried out and met with normal expected response unless we document. So if Mabel has been the same for the last 3 months, 3 years, happy, eats all her meals, ambulates in the hallway, goes to activities, incontinent, you know, if nothing has changed with Mabel, we don't have to document on Mabel. maybe once a month, okay, but that's all. If for one, you come in one day and she's not happy and she's not eating, then we need to document on Mabel because there's been a change in condition and things are not standard anymore, right? So you only have to write a longhand note when our standardized statement on the form is not met, when Mabel is not her normal, happy, healthy self, okay? So the advantage is it highlights the abnormal data and the patient trends because the only thing in the chart is going to be the abnormal data, right? And it decreases your charting time considerably, especially if you're working in long-term care and you have like 30 patients. You're not going to be able to document on all 30 of them every day. So this decreases your charting time and it eliminates duplication of charting because we're only documenting about a problem. We're not documenting that every day everything's normal. Okay. It does require detailed protocols and standards to be written, like what do we mean by normal? It requires the staff to use unfamiliar methods of record keeping and recording. And a lot of times you get so used to not charting that you leave before you chart, and you have to turn around and come back and chart about Mabel today, okay? You can't just leave it till tomorrow. It's got to be done today. So you'd have to come back. Computer assisted charting. These are the electronic health records. Electronic health records are wonderful things sometimes. Sometimes they're awful. All right, just depends on the program. But it's a computerized record of the patient history and care across all facilities and admissions. So you can go back and get all the history. The providers can put orders directly into the chart and it'll go directly to the MAR, it'll go directly to pharmacy, it'll go directly to the lab, wherever it needs to go. So that as a nurse, you don't have to transcribe the order into the MAR and call the pharmacy and get the med and all that. So we're going to document as you're doing it because you have the bedside computer. A lot of variations depend on what system you're using. We see a lot of Epic type charting, which you use in Ohio Health. Our simulation learning system is basically developed on the Epic principle, so it's very similar to what's being used in the community. We have some flow sheets that we document our interventions and expected outcomes. And then some of them are problem-oriented format, and they have a prioritized problem list that you document on. So date and time of the notation is automatically recorded, so we know if it's a late entry. Notes are always legible and easy to read. It's quick communication among departments because everybody can look at the chart at the same time, okay? It's on the computer. They can pull up a patient record. You can have the patient record. There's no fighting over the charts, all right? It reduces documentation time, makes for quick retrieval of electronic records. It's easier to get reimbursed for our services because they can just come in, look at the database and they're done, and it reduces error.
I have a question.
Yes.
What type of charting is usually done? Or is it just all of them? It just depends on the circumstances.
Depends on the circumstances. If you're using a problem-oriented system, then you're going to document a narrative note in your problem page, okay? So it's a combination of narrative note and problem. If you have just to document, you know, everything's fine, everything normal, so then you're just going to have a checklist on the computer, okay? And you just check those boxes and everything's fine. We don't have to worry about it. We only have to check the boxes that are a problem, okay? So it is very costly to set up. It takes a long time to implement because we have to train the staff on how to use the system. We have to have a security system to prevent unauthorized personnel from accessing records. And you want to make sure you never, ever, ever share your password with anybody, username and password, because if they go in under you, then whatever they document is under your name. Okay, their name will not be on the chart. Your name will be on the chart. Plus, we have to make sure that we are not violating HIPAA by leaving our computer open with the medical records open on the computer so people can walk by and see them. And then the last type is case management charting system. It's a method of organizing patient care through an episode of illness. So if they come in with clinical congestive heart failure, the case management system will say, well, within 3 days, they should be, should have gone from fluid overload to normal fluid balance. And this is how you're going to achieve that. And it's a flow sheet that says, yes, we did, or no, we didn't. So, but this takes the place of your nursing care plan. So if you have a clinical pathway or a interdisciplinary care plan, we don't need to write our own care plan. It's all there on the clinical pathway. Okay, so go ahead and take a break and come back at 10, and we will finish this up. Okay, welcome back. Okay, everybody see the accuracy and documentation slide up there? Yeah, no, maybe?
Yeah, I can.
Okay, just making sure because my machine's doing weird things today. All right, can't get my camera to turn on. All right, there I am. Okay, so accuracy and documentation. We need to be specific and definite in the words that we use, okay? And we want to make sure what we're saying conveys the meaning you wish to express. So what do you think it means when you say tolerated well? Is that a specific phrase that you can get all kinds of information out of?
Yes.
Really? What does that mean?
I took the medication, no reactions, a good outcome.
Okay, but it's also being subjective. You're saying, yeah, they tolerated it well, in my opinion. They tolerated it well. Wouldn't it be more specific to say no adverse effects from medication noted? Or you know, patient tell what happened, even if the, could be things like patient walked in the hall, something that will move towards your goals. That would be more specific, right? So we have to be careful. Ate well. How much did they eat? What did they eat? We have to be specific. Don't use those little catchphrases, all right? Brevity and documentation. Like we said, we don't need to write full sentences. We don't need to, include a and the. We don't need to put the patient in there. We don't need to put their name in there. Just write your facts, okay? We don't need to write a novel. We're just writing what we need the information to be conveyed to other people is, okay? So, and we can use abbreviations, but only if they are approved by your agency. There are many abbreviations that have been used in the past that are not acceptable now. So you have to be careful. You have to know what abbreviations are approved. And then you need to choose which behaviors and observations are noteworthy, right? The rule of thumb is that if the behavior or the finding is abnormal or it's a change from their previous behavior or data, we have to document it, okay? If they're still doing the same thing they did this week and last week and the week before that, we don't really need to document that. We do need to document any changes for the good or for the bad, but we have to document the changes. Legibility and completeness. Okay, if you are writing out a handwritten note, you need to make sure that we can read it. Okay, if your handwriting is really bad, you need to practice. We need to be able to spell our words correctly so that there's no confusion about what you actually meant. Okay, so get yourself a dictionary if you have to. This is where we need to learn our nursing words, our nursing vocabulary. All right, because if we're using nursing vocabulary, everybody in healthcare knows what that means. So we should be using our nursing vocabulary. All right. And be sure you include as much information as needed to convey what's going on with your patient. All right. So what are we going to document? Let's look at these boxes on page 98. I think it starts on 96. I don't know where box 7.1 is. Let's look at box 7.2, 7.3, and 7.4, okay? On page 98 and 99. So when we are documenting about a sign or a symptom, does every department require different note details? Well, you need to document what you're doing. You're not going to be documenting what they did in therapy because the therapist is going to be documenting that. Okay, so unless you are exercising the patient, then you're going to document that. So yeah, every department does their own type of charting. Okay. So when we're talking about a sign or a symptom, there are many things we need to include. We can't just say patient had pain. Well, that doesn't tell me anything 3 years from now, right? So we're going to use the guidelines, but I like to use PQRST. Okay. P is precipitating factor. What causing the pain? What is causing the pain? What were you doing when the pain started, right? Q is quality. What does the pain feel like? You know, pain's different. Some pains shooting pains, and some pains are pounding pains, and some pains are very sharp, and some are dull. Okay. Each type of pain has its own quality to it. So we want to make sure that we document that because that gives us a good idea of what's going on with the patient. PQR is radiation. Does that pain radiate anywhere? We all know that if somebody's having an MI or a heart attack or a cardiac issue, the pain's not just in their chest. It generally radiates either up to their jaw, to their back, or down their arm. Okay, those are good clues that we need. Somebody who's having a gallbladder episode, the pain is going to radiate up to their right shoulder. Okay, so where the pain radiates is important. S is severe. This is where we put in our pain chart, our pick a number between 1 and 10. 1 being the least amount of pain and 10 being delivering triplets. I don't know. 10 being the worst imaginable pain. Where do they put it on that scale? And by getting that scale, we're getting objective information. Okay. We're getting objective information that allows us to go back and ask them that question again and see where we are now. Okay. PQRST. T is time. Is it all the time? Does it come and go? How long have you had it? All right. PQRST. Those 5 things will give you good guidelines to document a sign or a symptom. Okay. Information to be documented on. It's not just, you pass meds and you did a treatment. We need to document if, we need to document a focus assessment every shift. If you're working in skilled nursing or the hospital, you're going to have to document every shift what your findings were based on what their problems are. You're going to have to document their degree. You got to document if they've had hygiene done or who did the hygiene. You're going to have to document if they died. Please write a nurse's note if somebody has died or discharged. Okay. And being specific for a death, you are not allowed as LPNs to pronounce somebody dead. So you will have to document that you found them without vital signs, without blood pressure, no pulse, eyes fixed, skin cold. Okay. Document what you see and that you called the doctor. Okay. And then somebody else has to pronounce them. You can document that you got diagnostic tests back. You're going to document diet and fluids, and that could probably be on an INO flow sheet. You're going to document dressings and wound care on the treatment administration record. You're going to document that they have an IV. You're going to document how much fluid they're getting through that IV and the I's and O. You're going to document what the IV site looks like, where it's at. You're going to document your medications, the patient's mental state and mood. If they have oxygen on, did the primary care provider come in to see the patient? What kind of post-op care we've done, procedures we did. If sleep is an issue, we need to document sleep. Somebody
Can I
have
ask
a
a
question?
question? Yeah,
Yes.
Chandra. If there's multiple nurses in there, like an RN and a nurse practitioner and an LPN, do they all take notes or with the same thing, or would it just
Well,
be
they're all
one?
going to document on what they did. Okay. So the RN's not going to do the same thing as the LPN, and the nurse practitioner isn't going to do the same thing as the RN. So you're documenting on what you did, okay? So any kind of tubes, equipment in use, we need to document all this information. So that 3 years from now, when somebody says, oh, I think they messed up and they were negligent, and they go to the lawyer, all that information's in there and you will be covered, okay? General guidelines for charting. We talked about a lot of these, but please verify that you are in the right chart. Verify that you're on the right computer screen, okay? Because it's very easy to document on the wrong patient, especially when you're in a hurry. We use a 24-hour clock or military time. And you can only document what you did or what you observed. You can't document what somebody else observed, and nobody can document for you. You have to do your own documentation. Okay, objective data is important. Never document the task before it is actually done. So don't sign off on your treatments. Don't sign on your MAR that you gave the meds if you didn't give the meds yet, okay? I know a lot of times it's easier, let me do it now and then I'll just go and do the treatment, but that's not the way it's supposed to work. You only document after you've done the task. You have to follow hospital policy. You have to clearly identify care given by another health team member. So if, you know, something got done by an STNA, we document that the STNA did it. If it was done by a therapist, we document that the therapist did it. If a patient refuses medication, which are their right, they are within their rights to refuse a medication. But we don't just walk out of the room, all right? First of all, we're going to record the explanation for why they refuse the medicines. We have to find out why, and then document the exact words the patient used when refusing, and then any instructions that you gave the patient and any patient behaviors that are against the instructions, okay? So if they're refusing a medication, we need a reason. We need to do some patient education. We need to call the doctor, okay? So those are things that we need to document. Make sure we're spelling our entries correctly. And if you suspect that a medical order or progress note is incorrect, make sure you get clarification from the person who wrote the order or the note, okay? If you make an error while you're documenting, we have to just correct that error by drawing one line through the words that are wrong, all right? And just write error and your initials, date, and time, okay? We don't ever obliterate or block off anything we've written, because then people will think that you're trying to hide something, okay? So it's always just one line through it. We're not going to use whiteout. We're not going to, you know, scribble on it to cross it out. One line, okay? So let's look at this critical thinking activity on page 100. Read that scenario, and then let's write a SOAP note about that scenario. So go ahead and read that scenario, and then we will get our SOAP note together.
What number did you say we were doing?
Scenario A on page 100 under the critical thinking activity. So is there any subjective data in this note?
No.
No, the patient didn't tell us anything, right? So there is no subjective data. What about objective data? We'll pick out the objective data.
The vital signs,
The vital signs, yes.
He's coughing,
Okay, not only is he coughing, what is he doing?
Spitting out
Spitting
yellow
sputum.
green sputum.
Pulmonary secretions.
He has pulmonary secretions, but it's better to describe those pulmonary secretions, right?
yeah.
So
Excess.
he has a cough producing yellow-green sputum would be an objective statement. All right, what else is objective?
He has difficulty
enough.
stopping the cough.
Okay, and what else? One more.
His respirations with the
You've
shallow.
already counted this, right? You've already put the respirations down in the vital signs.
Then we get temperature.
He's
Okay,
on oxygen.
oxygen.
Nasal.
Oxygen via nasal cannula at 3 liters per minute. And did they give us a pulse ox? No, they did not. Okay. So that is your objective data. What is your assessment of this problem?
That he has acetaminophen and that we'll be giving him that, and that
No, that's your intervention. What's your assessment?
The patient
Medical
has
diagnosis.
pneumonia with difficulty.
Okay, so the patient's having respiratory difficulty due to his pneumonia, right? That's your problem. Okay, your assessment. And now your plan is to do the acetaminophen, right?
by the way, what'd you say it was?
Okay, so your assessment is respiratory difficulty related to pneumonia. And now what is your plan?
The plan would be to give him
With
the
the administrative medication.
medicine for the fever and for the cough.
Mhm. No, your plan is you're gonna give him the medicine for the fever, but you're gonna call the physician for the cough medicine, right? You have to be specific. You don't have a medicine for the cough yet. You need to call the doctor and get an order. So that's how you would come up with a SOAP note, by just looking at the data you have gathered. That makes sense? Okay.
Yeah.
You couldn't order an x-ray either, right? That would all be the physician.
No, physician has to do that too, but that could be when you, remember SBAR? When we talk to the doctor, we can recommend things like, hey, do you want an x-ray? So yes. All right, let's move on to chapter 8. Communication is it's basically a learned skill. You just don't start communicating. You learn a lot when you're a child, but when you're a nurse, we have to communicate in a specific way, okay? And so we have to remember all the points that go along with that. Share screen.
Take a look.
So chapter 8, communication and the nurse-patient relationship. So when we are communicating, we are actually in a feedback loop. Okay? Communication occurs when one person sends a message, another person receives it, processes it, and indicates that the message has been interpreted. Okay, so if you look at the picture on page 102, all right, your message is that here's your call light, press your button if you need me. The patient receives the message and says, I press the button here and you will come. That means, hey, they caught my message now, right? And it goes back to the sender and the sender verifies, yes, you're right. So it's a continuous loop. Okay? And it can be either verbal or nonverbal. And remember, nonverbals speak louder than verbals sometimes. All right. If you're upset, if you're angry, and it's written all over your face and you got your arms crossed, the patient's going to feel like you really don't want to be in the room with them. So nonverbals are very important. When we're talking about nonverbals, we're talking about gestures, body position, intonation, and your general appearance, or your patient's general appearance. Okay, your patient can give you nonverbals also. So things that affect communication. All right. First one would be cultural differences. Many different cultures have different ways of communicating with people. A lot of it has to do with how close they get to people, how eye contact is another issue with cultural difference. So, you know, the little box there about eye contact and cultural considerations, how it's not polite to have direct eye contact with many different cultures, not just the Japanese culture that they talk about here. But you need to know how your patients communicate and what's going on with them, so that you can be considerate to them. Okay, it's not just how we communicate, it's how they communicate. Because as Americans, you know, I expect people to look me in the eye when I'm talking to them. However, I had to learn that not all cultures do that, and that they are still listening to me if they're not looking at me. Okay, so you have to pick that up as you go along with the cultures that you're working with. Past experiences. Okay, everything that we've had in the past affects how we perceive communication. Okay, if you've had a problem with an instructor in the past, all right, and now they're going to, you know, that you're talking to them and you're trying to get a problem solved, you're going to keep that past experience in the back of your head and say, she's really not trying to help me. Okay, and that'll come through in your conversation. All right, or if you've had a great experience, then you're going to relax and expect that person to be able to help you. Emotion, mood, and environment. Okay, stress. Patients can't hear you if they are anxious and stressed. Okay, students don't hear me when they're anxious and stressed, right? If you have a test and you're all stressed out about the test, you're probably not listening really well to all the other things I'm saying before we start the test, right? You're all focused on that test. Well, it's the same thing with your patients, okay? If you have a depressed patient, they tend to not talk a whole lot, not look at you. So the emotions and the mood are very important to understand when you're communicating with somebody. Attitude of the individual, okay? So that could be you or it could be your patient, okay? And it affects how messages are worded and the body language that accompanies it, okay? So if you have a negative perception of and disapprove of the patient's behavior, you may be showing closed body positioning, body language. You may have your arms crossed and you're tapping your foot and you've got this look on your face like you want to kill them. Yeah. So yes, so try and be open and attentive when you're communicating with your patients, and be have a non-judgmental attitude. And don't take anything personally that your patient says, because they are probably stressed and in having problems dealing with the situation. So don't take it personally, okay? Okay, communication skills. Communication starts with active listening, okay? You need to focus your energy and your concentration on your patient and actively listen to what they're saying. Don't be trying to come up with the answer in the back of your head while they're talking. Listen to what they're saying. Don't be trying to figure out what you're going to say next. All right, you want to use all your senses to interpret the verbal and nonverbal messages. You're getting feedback. You're giving feedback. Okay, remember it's a loop. Listen for feelings as well as words. They may tell you they're fine, but they're crying. Now, is that I'm fine and they're crying? Is that you know, an equal reaction? No,
No.
no. Okay, so you have to look for the feelings too. And maintain eye contact without staring and make a conscious effort to block out distractions. As a nurse, you will have 1,000 distractions every minute. Okay, but when you're taking care of your patient, you need to be there physically and mentally taking care of your patient. So when we're talking about nonverbal messages, you're observing your patient for their posture. Are they all tense or are they really relaxed? Okay, what kind of gestures are they making? All right. What's the tone of their voice? Are they calm? Are they sharp? Are they angry? What's their facial expression? Are they smiling? Are they frowning? Are they making eye contact with you appropriately? Okay. So those are all nonverbal messages you can look for. Okay. And then we need to give feedback. Get the feedback from the patient that they heard what we said and they understand what we're saying, okay? It's vital to see if the patient has interpreted the message the way you meant it. All right? Just like I ask you guys questions, I'm getting feedback from you that says that yes, you heard what I said. All right? So there's different ways to obtain feedback. You can rephrase the meaning of the message or you can directly ask a feedback question. Okay. Keeping your attention focused on the communication task at hand is important. It makes the patient feel like you are really there for them. And make sure that make sure that we're all still on the same topic that we came in there to talk about. Because a lot of times you can be going in to do your assessment and you're gathering information and the next thing you know, you're talking about cats. Okay, we need to pull that conversation back to our assessment because sometimes people try and deflect us with other topics. So occasionally check to make sure you're still doing what you were supposed to be doing. And we need to adjust our style to the patient's style. So if a patient is a slow, calm communicator, they have many pauses so that they can gather their thoughts. We need to be respectful of that and just wait for them to get their message out to you, okay? If your patient speaks quickly, then we want to make sure that we kind of match their pace, because if they're talking, you know, fast to getting the details out fast, we don't want to be very calm and slow about how we answer them, because that'll drive them nuts, okay? Just like I talk too fast for you guys sometimes, and you have to tell me to slow down. We have to match paces. Okay, and if the response is slow in coming, please allow time for consideration and a response. You know, you may ask a question and not get an answer. Somebody's really trying to get hold of me. And yeah, you have to wait for the answer, right? You can't just give them the answer if they don't give it to you fast enough. Okay. Therapeutic communication techniques. Okay. So these are all listed on table 8.1 in page 105. All right. Promoting communication between the sender, receiver, and obtaining feedback. That is how we communicate. Focusing on the communicator, focusing on your patient. Using silence. Silence is really hard. It's really hard to sit there quietly while you're waiting for the patient to come up with the answer. It makes you uncomfortable, okay? And you want to fill in the gap, all right? So silence is something you need to practice. Open-ended questions are very, very important, you know, so that we get more than a yes or no answer. We want to ask a question that allows the patient to elaborate on the answer instead of just saying one or two words. So, you know, Tell me more about that. I'd like to hear more about, or even when you're talking about breakfast, you don't just say, did you like your breakfast? Because you got a yes or a no answer. But you say, what did you think about the pancakes? Okay, that makes them actually talk to you about the pancakes. Make sure that the patient knows that you are there, showing concern and caring, and you're ready to help. These two next ones, restatement and reflection, be careful about how much you use them, because I know some patients get really agitated when you keep saying the same thing back to them, because they're going to think you're not listening to them. So use these use these wisely, okay? So if the patient says, I tossed and turned last night, and you say, oh, you feel like you were awake all night, that's clarifying what they're saying, okay? But if you reflect it, and so, yeah, oh, you tossed and turned last night, that's what I just told you. Make it a different answer, all right? Clarification, okay? So seek clarification to see what's going on. Focus. Find a focus for your conversation. Encourage elaboration and give information. If the patient has all the information they need, they will be less stressed. So, if you do a blood draw, or you do a diagnostic test, you got to tell them when they can expect an answer about this test. It'll decrease their anxiety. Okay. Looking for alternatives, saying things like, have you thought about, or what about this? Okay. And we talked about silence, and then we should summarize our conversation at the end. Okay. So you're having pain, so I'm going to go get you some pain medicine. I'll be back in 5 minutes. Summarize. All right. Blocks to effective communication. These are much easier to come up with than the therapeutic things, right? Those are on page 109. All right. Changing the subject. Your patient says, I'm really worried about this test today. And you totally ignore that and say, what do you want for breakfast? Okay. You're not addressing the need right there. Giving false reassurance. Oh, it'll be fine. Don't worry about it. No, that's not helpful. Being judgmental. Are you sure that's a good thing for you to be eating because you have diabetes? That's very judgmental. Or, what in the world were you thinking? That's judgmental. Okay? This is not how we talk to our patients. If the patient says something negative about patient care or the facility, or a football team you love, whatever, we don't get defensive and defend them. All right? Everybody's entitled to their own opinion. So using cliches. What is a cliche? Can somebody tell me what a cliche is? Anybody know any cliches? Okay, cliche is a statement that you make that just kind of a broad definition, like the grass is always greener on the other side. That's a cliche. Or it's always darkest before the storm. All right, that's not helpful. That's not being, it's not, identifying the patient's situation. It stereotypes the patient and it negates their feelings. So please, no cliches. We don't give advice. We don't say, well, if I were you, I would try this treatment because I've heard this works really good, or I would try this diet because this works really good. That's not your job to give opinions. It's not your job to give advice. And then if you're not listening to the patient, that's going to totally block your method of communication here, right? If you have your back turned to the patient and you're cleaning up the tray table and you're looking at your phone, you're not going to be attentive to the patient. You're not going to get much communication out of them. Okay, everybody understand those? Yes, no, maybe, shake your head, raise your hand, something. Okay. All right. Because I'm sure there'll be questions on the test about those. So Andy is having difficulty communicating with his patient. His patient barely understands English. He's highly anxious about being hospitalized and doesn't look at Andy when he's speaking. So what 4 factors are affecting the communication here?
One,
Okay, why did you say 1?
because he doesn't speak English. He probably had, he's probably highly anxious about being hospitalized, which is probably like past experience.
Mm-hmm.
And he's not looking at him when he's speaking. So that's probably like his emotions, and he's probably like just, I don't know, like feeling down or.
Okay,
Getting
very good.
frustrated.
He's frustrated, yes. So yes, that's very good. So Holly is trying to encourage her patient to elaborate rather than apply in short 1-word answers. Her patient relates to Holly that she doesn't feel safe at home. So Holly says, would you tell me more about this? What type of communication technique is this?
Clarification? No, wait, open-ended question.
It's open-ended question.
It is an open-ended question, but we're doing it specifically to a situation. So it is
Perfect.
encouraging elaboration. We're encouraging her to elaborate on this situation.
Oh, okay.
Okay, it's always the best answer, guys. Marisol's patient is a diabetic. Marisol notices her patient eating cheesecake and a cola from a visitor and states, I don't think that's a good thing for you to be doing considering you have diabetes. What communication block is that?
Judgmental response.
Very judgmental, yes. Are you going to get any cooperation from your patient with that?
No.
No, they're going to have another piece of cheesecake. So Emily's patient is very nervous about her surgery. She's having a breast biopsy. Emily tells her patient, I'm sure it'll turn out fine. You don't need to worry. What communication block is that?
2.
Using
Yes, we're giving her
cliche.
false reassurance. We don't know. We don't know what that breast biopsy is going to show. Okay, so no, we're not going to say that. Okay, so now we're going to talk about communication strategies in specific circumstances, and we're definitely going to talk about communicating between healthcare providers. Okay. So, as a nurse, and especially as a new nurse, you're going to have to develop your interview skills. Do you remember when we talked about when we were doing assessment? What's the 3 parts of the interview?
The opening, the body, and the conclusion.
Right, very good. And what do we do in the opening?
The opening is where we build rapport
Yes,
with the patients.
very good. And what do we do in the end?
We summarize
Very
the
good. That too. Excellent. Good job. Okay. So
Can you say that
developing
again?
your, pardon?
Can you say that again?
Okay, so your opening is where you build rapport. Okay, you're going to kind of come on a common ground here with your patient. The middle part is the body of the interview, is where we're going to gather all our data. And then the ending, we're going to summarize what we learned, just so that the patient and you are on the same page. Okay. It's also a challenge to build that nurse-patient relationship. Nurse-patient relationship is a professional relationship. It is not a personal social relationship. Empathy. What is empathy?
Sympathizing.
No, sympathizing is something different.
Putting yourself in their shoes.
Right. Empathy is putting yourself in their position. It's not just a over blanket of, oh, I'm so sorry. Okay. It's actually trying to feel what they're feeling. That's empathy. And so using empathy is a skill you need to learn. Becoming non-judgmental is a skill many of us need to learn. I had to learn it when I was a new nurse, and you guys will probably have to learn it also. Maintaining hope. do not let the situations get you down. Always maintain your hope, okay? Hope for you, hope for your patient, hope for the world, okay? We always apply the nursing process, and as nurses, you're going to be applying the nursing process throughout your lifetime, every day, in every situation you're in, after you start getting into the habit of looking at assessments, problems, implement plans, implementation, and evaluation, okay? And then we have challenges for communicating with hearing impaired, elderly children, and people from other cultures. So communicating with the hearing impaired. Okay, this is on page 113 in your book. We want to make sure we speak very distinctly, but we do not shout. If you're shouting, you're exaggerating your words. They're not going to understand what you're saying. All right. You also want to speak slowly. Most people who have hearing impairments do some form of lip reading, so we want to make sure we're standing in front of them and that our mouth is clear so they can read our lips. And it makes it a challenge with masking these days. We want to be about 2.5 to 4 feet away from the patient. You don't want to be across the room. You want to watch your patient for nonverbal feedback to see if they're actually understanding or getting the message you're giving. And that's all part of your communication loop. Use short sentences, and sometimes you have to paraphrase what you said for clarification. Okay. When we're communicating with an aphasia patient, aphasia is a neurological disorder where the patient has difficulty expressing or understanding language. So they may know what they want to say, but the words don't come out. They can't get the words out, or they give you a different word than they mean. So aphasia is very challenging. All right. When you're talking to somebody who has aphasia, we need to be patient. We need to make sure that we have their attention before we start, especially those that have problems understanding what you're saying. Okay, because there's different kinds of aphasia. There's expressive and receptive. Okay, you have to assume that the patient can understand what is heard unless there's deafness. You have to talk to the patient. Don't talk to somebody else in the room. Okay. About the patient. Give the patient a chance to answer. We need to be patient. All right. Include them in group conversations. Give directions in short phrases and simple terms. And make sure, things that are yes or no are much easier for them to be able to answer. So here we're going to use questions that are yes, no. Using body language, gestures, facial expressions to enhance the message is important, because what they see, they can understand, not necessarily what they hear. Okay. And praise all attempts to speak and downplay any errors. We're not going to insist that they say each word correctly, as long as you understood what they were saying. And encourage independence and avoid being overprotective of somebody who is aphasic. Okay. Speech therapy is really good at identifying methods that the patient can communicate with, and they share that information with the nursing staff, so that's how you will communicate with the patient. Older adults, we want to make sure that they don't have a hearing deficit or a visual deficit before we start talking to them. We need to slow down and give them time to answer questions, and wait for that answer of one question before we ask another question, because that's just going to confuse the issue. And get feedback to make sure that they're hearing what you're saying. Okay. Children, we want to approach them at eye level, and most of you have kids out there, so you know this. You want a calm, friendly voice. You don't want to scare the children. Okay. Keep your sentences short. All right. Give simple explanations. Allow them to handle the equipment. Allow them to handle the stethoscope and the pen light and things like that. Not anything that's going to hurt them, but let them see and feel and see what it's about. It'll be less scary for them to do that. Communicating for people with other cultures. First of all, we have to determine what language is being spoken and get an interpreter if necessary. Now, we can get enlist the aid of a family member if we're talking about what do you want for lunch, or, you know, simple things like this. But if we're doing a physical or a health assessment and we're talking about medical issues, we really do not want to have the family to be the interpreter in this, because there are times where the family member doesn't want to tell you what the patient said because they'll be embarrassed, or the patient doesn't want to share that information with their daughter or their son. So when we're looking for medical information, it's much better to get an interpreter. For everyday things like what do you want to wear, and, you know, what do you want for lunch, the family member is perfectly appropriate. If available, give them printed material in their language and answer questions. All right. And beware of cultural differences in eye contact and personal space. Okay. We communicate with healthcare team members, and I know that we talked about, or I had the slide up about the NCLEX, where communication is a safety issue and it's part of the interdisciplinary team and things like that. So we communicate through our nurses' notes. If they are, you know, accurate, it gives people a lot of information. The physician communicates to us through orders and progress notes. The dietitian will communicate through their notes. PT and OT and speech have notes. Shift report is very important for communication and for safety. And then your laboratory findings. Okay, so let's start with talking to primary care providers, physicians, nurses, nurse practitioners, medical practitioners in general. Okay, before you call the doctor or anybody about a patient, make sure you have assessed the patient and you know what's going on. You have to have a set of vital signs. All right, have the patient data at hand, their laboratory, their new labs, their vital signs, what's their urinary output, what kind of medication are they on. Have that chart in front of you so you can look up that information and not, you know, delay getting the information to the doctor. Okay, know the patient's allergies, because if the doctor's going to order medication, you need to know if that's safe for your patient. Okay, prepare a concise problem statement. Okay, remember, when you're doing an SBAR, the first thing we're going to tell them is the situation. Why are we calling? All right, and then document that you call the physician and their response. As a nurse, you're going to assign people to do work, and you're also going to delegate work to other people. All right. When you're delegating nursing responsibilities. When you're assigning, you are just divvying out jobs that they are supposed to do anyhow. So you're assigning rooms to your aides and your techs. But if you ask them to do the vital signs, then you're delegating that nursing responsibility to them. Okay. When we do this, we want to give clear, concise messages and listen carefully for feedback to see what kind of objections they have or if they have questions. All right. When you're delegating, we want to give the what result we want and when we want it. Okay. So if somebody has an appointment that morning, you want to make sure that you tell the aides in that assignment that you want to make sure that they've been bathed and dressed and they're ready to go by 9:15 when the transport's going to come and pick them up. Okay. If you're delegating a task or assigning a task, make sure they don't have any questions about what needs to be done, and then ask for a summary so you can verify that they understand what the task is. We use computers for communication. We use cell phones for communication. We use all kinds of things for communication these days. All right. It's very easy with the computer to transmit requests for labs and dietary and all that. Hopefully you got physicians that are using the medication system so that they can put your medication order directly on your chart and in your MAR, etc. We use computers to get supplies, to update patient care plans, and then there's computerized charting. When we're working in the home or in the community, we need to make sure that we state when instructions are about to be given so that we can get everybody's attention in the house when we need it or in the community. Leaving written step-by-step instructions whenever possible for the patient. This could be in the hospital before they're discharging, or when you're sending them home, or when you're working in the home with them. All right. And a lot of times office and clinical nurses have to assess the patients who call in to see what their need is and how urgent it is for medical attention. So that's called triage. Sarah just graduated from nursing school. She realizes all the following statements are true regarding communication, except what? What is not true? Only one answer out there?
Three.
There we go. No, 3 is true. Okay, we want to avoid things that are gonna block communication.
2,
2 is correct. When we're communicating with a child, we don't want to speak loudly, right? We want to keep it a calm, even tone. So the correct answer here is 2. All righty. Any questions about communication? Okay, so take a 10-minute break, come back at,
Yeah, I have a questions very quick.
yes.
So you spoke about using equipment and how to work with children, and you said in some cases we should allow the children to handle the equipment. But basically, it depends the circumstances is where critical thinking come in because some equipment are harmful and probably it depends on the child. They may tend to break the equipment or throw it down, like
Mhm.
drop it on the floor.
Right, I mean, we
Yeah.
need to assess the situation and see, I mean, some things are easy for them to look at. All right, depending on the age. Now you're talking about maybe 4 through, early elementary. They're the ones that really need to be, involved in the process. Okay. An infant is not going to help if you let them play with the pen light because they're just going to chew on it. So you have to assess the situation and what equipment. We're not going to hand them a needle to look at, right? So yes, we need to assess the situation. That's a very good point, Fatu. All righty. Take a 10-minute break, come back at 5 after 11, and we will do physical assessment.
I do have a question, Prof.
Yes, Charles.
Okay. So under the blocks of effective communication, we made mention of cliches, saying that shouldn't be used. So my question would be also be under the nurses-patient relationship where we have to maintain hope. So how do you put the two together? The use of cliche and maintaining hope.
Okay, well, I mean, you're right, cliches and hope are a lot the same. But, I think hope is more of an attitude than a cliche. Hope is not, going to say that it's going to be, this won't hurt or you have a long life ahead of you. Hope is we have this treatment plan and we're working on it. It's not a cliche. Does that make sense?
Yeah.
Okay. All right. Anything else? Good questions, guys. All right, we'll see you in 10 minutes. Okay, let's start getting back together here. All right, we need to get the cameras back on so I can see your shining faces. There we go. Time to get back together. Turn your cameras back on. Okay, so let's talk about chapter 22. Last week we talked about vital signs, which is part of your health assessment. Okay. This week we're going to talk about assessing your total health assessment. Now, when a patient is admitted, when a patient is new to your care, then you're going to do a complete head to toe assessment, ask all the interview questions, et cetera, et cetera. Every other shift after that, when you take care of that patient, we're going to do what we call a focus assessment, which is just going to focus on the problems that the patient are having. We don't have to go through the whole social history and all of that every time. So as a bedside nurse, you're very rarely going to have to do this complete head to toe assessment, but we'll talk about the one that you will have to do too. Okay. Remember that with your nursing process, assessment is the very first step. So we're gathering data, and we're always gathering data. We start gathering data the minute we see a patient come down the hall. Okay. We're looking at their skin color. We're looking at how they move. We're looking at, are they alert and oriented? Okay. These are things that we are continually assessing. All right. So your initial detailed assessment on admission is going to include your physical assessment, your history and demographic data, information pertinent to daily care and current health problems. All right, it's going to get all the database put together. Then currently, or a focus assessment on every successive shift after that to see if we're meeting our care plan. So you have to be aware how the illness is affecting the patient's life. And remember, we nurse holistically. So we're not just worried about the hip. We're worried about how that hip is affecting every other part of their life. Okay. And so we need to assess for cultural preferences and health beliefs also. You're going to run into patients that are very much against Western medicine. They're in the hospital because they have no choice. And they've been using traditional forms of medication or traditional forms of treatment culturally before they got to you. All right. So we have to assess their health beliefs. And then we need to rephrase questions in a positive, non-threatening way. And we just talked about all that with communication. Okay. The other thing is, don't assume just because somebody is in an ethnic group that they believe or practice everything common to that group. All right. You need to find that out. So your initial assessment is going to include social data, their marital status, their occupation. It's going to check to see if they have anything that comes out like dentures, prosthetics, artificial eyes, hearing aids, all that stuff. Always check for allergies. on your initial assessment and every other assessment after that, okay? And make sure that your chart is labeled that there are allergies. We would need to know what kind of medication they're taking so that we can reconcile the medication list that they had with what they're taking now. And sometimes you have patients who are in the hospital for something totally different, but they have glaucoma. Well, they need to have their glaucoma eye drops every day, regardless of what else is going on. So we have to make sure that we've gotten their health history so we know to get their glaucoma drops ordered. We're going to talk about the diets, any limitations, any special foods they need to eat. We're going to talk about smoking. We're going to talk about the use of alcohol. Okay. And you know, these questions about alcohol, drugs, and smoking, they tend to put people on edge because they know it's not what you're expecting, that you don't want to see them, that they smoke or they drink or they do drugs. Okay. So, you know, there are some potential questions you can ask about alcohol abuse in adults on box 22.2. And there are also questions you can detect about physical, sexual, or alcohol abuse, okay? So signs and symptoms for possible abuse are also on page 378. And you shouldn't be aware of those, okay? And we need to know why they're there. What is the reason they came in? Then we start our physical assessment or our data collection with our physical data. So there are a lot of things on page 377, your interview guide, that you're going to ask them about in the initial assessment. Okay, you're going to ask these kind of questions so that we get a baseline of what's going on with your patient. All right, so you want to know things about, you know, headaches, dizziness, ringing in the ears, coughing, any kind of history of lung problems. Have they had tuberculosis? Have they had COVID? Do they have COVID? Have they been exposed to COVID, right? Abdomen, genitourinary, extremities, and endocrine. These are all topics that we need to talk to our patients about on their initial assessment. Okay, and then we will start our physical assessment. Okay, we're going to look at picture of physiological functioning here now. Okay, so we're going to do this physical assessment to get information to be used to determine their health level, their physical functioning, to confirm their diagnosis, confirm their dysfunction, indicate specific body areas that we need to pay attention to. Okay, there's a lot of reasons we do this, but it's going to give us a complete picture. Okay, after we've done our initial physical assessment, after that, you're only going to do a focus assessment, which is a brief scanning type examination and combined to a specific system. So there are techniques that go along with assessing our patient. We're going to use our senses. We're going to use our sight. We're going to use our smell. We're going to use our hearing. We're going to use our touch. Okay. We're going to be using our senses to evaluate our patients. All right. So the first thing we do is we inspect and we observe. No matter what body part or body system you're looking at, the first thing you're going to do is inspect. So you're looking for their general appearance, their contour of their body. Are they extremely thin? Are they extremely obese? All right. Skin tones, color, rashes, skin lesions, deformities, extremity, weakness of extremities. Okay. This is your visual full body assessment right there. Okay. We're going to check and see what potential problems we have. Okay. So when we're doing specific systems, we are going to look at the patient. So if we're looking at their head and neck, we're going to look to see if their face is symmetrical. We're going to see if, you know, they have any drainage from their eyes, ears, nose, or mouth, you know, those kind of things. That's your inspection. Then we're going to do palpation. So after we use our eyes, we use our hands. Okay. So inspect, and then we're going to palpate. And here we're looking to ascertain shape, size, and position of body parts, presence of tenderness, swelling, if maybe you feel a lump or a growth somewhere, You're looking at skin temperature, and if you use the back of your hand to check skin temperature, it's much more accurate than the top of your palm. All right, presence of edema. So is there any swelling anywhere? This is what you're laying your hands on for. And then after we finish our palpation, we also do percussion. And percussion is where we're tapping on our fingers that are sitting on a body part. And what we're looking for is a dull sound or a hollow sound, a drumming sound. So when you're doing this, we're looking to see how big the organs are. So say we're percussing on the abdomen, and you're going to expect on an abdomen to hear a lot of drumming sounds because there's a lot of open space, air in there. There's intestines are big tubes. There's, open space, but you also have your liver and your spleen in your abdomen. So you should not be hearing a dull thud more than maybe a finger width below your ribs. That's your liver. Okay. If the liver is really big, you're going to have a dull thud in an extensive area in the upper abdomen. Okay. So density of the organs, size of the organs, and we're looking for air or fluid in body tissues. If you percuss on the lungs on the back, you should always hear a drummy sound because your lungs are full of air, right? But if you have your lungs full of fluid in the bases, you may hear dull thuds down there and then get your drumming sounds up on top. So inspect, palpate, percussion, and then auscultation, where we use our ears to listen to various body parts. Okay, so using for presence or absence of sounds, using a stethoscope. Okay, so when we are listening to lungs, we want to listen to all the lobes. Remember, you have 2 lobes on the right, the left, and 3 lobes on the right. So you want to listen to all the lobes. When you're listening to the heart, you want to listen to all the areas that you can hear the different valves in the heart to make sure they're all functioning correctly. When we listen to your abdomen, we're looking for bowel sounds. Okay, bowel sounds are those gurgly sounds that you hear, like when people are really hungry, you hear them really loud. Okay, but now you should be hearing bowel sounds in all 4 quadrants of the abdomen to make sure that we're having normal bowel function. So when you're listening, I told you there were specific areas of the heart and lungs we should be listening to, and we'll get back to this. But there are specific places to put your stethoscope to hear these types of areas, okay? Anything that's on your chest, you want to put your stethoscope between the ribs in what we call the intercostal spaces. All right? You'll hear much better if you're not trying to listen through bone. So if you're listening to the heart, we're going to start on the right-hand side in the second intercostal space, and then move to the second intercostal space on the left. We're going to move down to the 3rd intercostal space, the 5th intercostal space, and then the 5th intercostal space interclavicular, so on the clavicular line. Okay, and then we can use our nose. Sometimes your nose gives you more information the minute you walk in the room, right? You're going to identify odors characteristic of certain problems. You can identify somebody who has alcohol in their breath. You can identify somebody who has a sweetness or an acetone smell to their breath, because that gives you an indication on their diabetic status. The odor of wounds. Different bacterias have different odors. Like Pseudomonas is kind of like a flowery odor, okay? But then you have other ones that smell like tuna. And then odors from discharges that will also give you information about what's going on with your patient. So we start our basic physical examination with height and weight. Okay, no shoes on, usually on a standing scale for adults, a platform scale for infants and small children. Okay, we don't want to weigh the diaper on an infant. Okay, and we never leave them unattended. After we get our basic height and weight, we want to do our vital sign measurements. So what are your vital signs?
Oxygen level,
Temperature, pulse, pain level.
Blood pressure.
Blood
blood
pressure, Remember, we do TPR, blood pressure, and pulse ox, right? And the last one is pain. So your 5, 6 vital signs. And then we're going to start reviewing our body from top to bottom, head to toe, okay? On a initial physical assessment, we're going to hit every body system, all right? So we're going to look at the head, the neck, and then we're going to move down to the chest, where we're going to listen to the lungs and check out the heart. And then we'll move into the abdomen, which is right below your lungs, go into your genital area, and then go into your extremities. That's how you're going to organize your assessment, okay? When we're looking at the head and neck, we're looking at the general appearance, we're looking at the appearance of the eyes, okay? Are they glassy? Are they open? Are they closed? Are they red? Are they crying? Condition of the hair, okay? Is their hair dry and falling out? Do they have a nice head of hair? Do they have lice in there? All kinds of things you can find in the hair, right? Difficulty in hearing or seeing. And you can check hearing just by talking to somebody. If it doesn't appear that they are hearing you, they probably aren't. When we check our pupils, when we look in the eyes, we're going to use a pen light and we're going to check for perla, P-E-R-R-L-A, perla. Pupils are equal, round, reactive to light, and accommodating. That's what perla sounds like. And when you're documenting, if all those things are true, then we can just write perla. All right. Your pupils should always be equal in size. They should always be round. Some neurological disorders, they get to be funny shapes. When you shine a light in them, when you shine the light in the eye, it should be constricting the pupil. The pupil should get smaller. When we talk about accommodation, we're talking about looking at something close up like my finger and then looking at the corner of the room, okay? And your pupils should change. That when you're looking close up, they should constrict, and when you're looking across the room, they should dilate and get bigger. Are their corneas clear? Is there opacity? Are there cataracts? And you're going to go through all of this in lab, okay? I know it's a quick lecture, but you're going to go through this, get your hands on here, okay? And then we're going to look at the chest. Remember, we're looking first. So we're looking for symmetry in the chest. Are both sides equal? All right. Are their shoulders both in the same place? That when they breathe, does their chest expand normally? Both sides expand the same, or just one side expands? Those kind of things. Any signs of lordosis, kyphosis, and scoliosis? So who knows what lordosis is? Are you awake, Whitney? Okay, just checking. Lordosis. Lordosis is like a C-shaped spine where the shoulders and the hips are back and the belly's out. You see this a lot with pregnant women who have very big bellies and they're trying to balance. That's lordosis, okay? Kyphosis is the hunchback, okay? So they're hunched over, kyphosis. And scoliosis is the spine is not straight. It's got like an S curve to it, okay? Dyspnea, what is dyspnea?
Difficulties breathing.
Difficulty breathing, very good. A noticeable point of maximum impulse. Sometimes when you look at a person's chest, you can see their heart beating down here in the mitral area. Okay, you can see that, and we call that point of maximal impulse. Okay, and then we're going to listen. But what are we going to do after we inspect? Inspections first. What's the second step?
Auscultate.
No, we're going to palpate, right?
Okay.
You're gonna see if the lungs are expanding equally. You're gonna see if you can feel that point of maximum impulse. Okay. Then we're going to auscultate. Okay. And we're gonna listen to heart sounds. And a normal heart sound sounds like lub dub, lub dub, lub dub, lub dub. Okay. All right. Nice, even rhythm, lub dub, lub dub, lub dub, lub dub. If you have, that's an irregular heartbeat or called a dysrhythmia. All right, you can feel a dysrhythmia when you're palpating a pulse. You can hear a dysrhythmia when you're listening to a heart. Okay. And then we're looking for apical pulse rate normal. And where are we going to check for the apical pulse? Where do we find your apical pulse?
Third in the call space.
Close, fifth intercostal space, mid-clavicular line. Okay, that's where you're going to find your apical pulse. And if you have an abnormal pulse, a dysrhythmia, if your pulse is not regular, then you have to listen to an apical pulse for 1 full minute. What's a normal pulse rate, heart rate?
12 to 20.
Nope, that's not heart rate. If your heart's only beating
Right.
12 times a minute, you're in trouble.
60 to 120.
60 to 100, okay? So yes. So then when we're listening to lungs, we're gonna listen over your trachea and then your upper chest area and then your central chest and back, okay? And there are 3 different kinds of sounds you're gonna hear when you're listening to lungs. And if you look on page 385, it shows you the area where you're gonna hear these sounds. You're going to hear bronchial breath sounds right up here around the trachea and in the bronchial tube here. You're going to hear bronchovesticular sounds in the middle of the chest and then vesticular sounds on the outer edges of the chest. Because remember, your lungs have your bronchioles that go and then they split again into little alveolar sacs. So that's where you're going to hear the vesticular sounds. And then we have what we call adventitious sounds. Adventitious is always an adventure because it's not normal. Adventitious is always an adventure because it's not normal. We don't want to hear these adventitious sounds. So our adventitious sounds are, well, they're described on page 385. We have the wheeze, which is a high-pitched musical sound. Usually you hear it on expiration, but sometimes you can hear it on inspiration, and basically means that the airway is constricted. It's keeping the air from getting out. So it's like blowing through a whistle, okay? Or a gurgle or a low-pitched wheeze is also called rhonchi. And rhonchi you're going to hear in the bronchial areas, okay? And it basically just sounds like they need to cough. You're going to hear gurgles and pops, and they need to cough to get the junk out of their lungs. Okay. Crackles are fine, coarse, non-musical sounds. Some people say they sound like if you twist your hair next to your ear. Other people say they sound like Rice Krispies, and they do. And that's your alveoli opening up. Okay, remember in the alveoli, we have our gas exchange, and if that's collapsed, and then they take a deep breath, it's going to pop open and then collapse again. If there's fluid in there, you're going to hear that popping sound. Okay. Stertor is a snoring sound produced by inability to cough up secretions in your trachea. Stridor is a crowing, croupy sound, croaking sound, meaning we have a partial obstruction of the upper airway. And then your pleural fiction rub is a grating, scratchy sound. It's caused by irritated pleural membranes rubbing together. And that's on the outside of the lung. So when we're listening to lungs, we're going to start up here above your collarbone because your lungs go all the way up here. All right. And you're going to start here and you're going to go across, and we're comparing side to side. So you're going to go across and then down and then across and down, across and down, across and down and across. Okay, so there's 5 areas you want to listen to on the front. Basically, it's all in the rib cage. Don't be listening lower than the rib cage because then you're in the abdomen. All right. And you're trying to hear those bronchial and the bronchial vesicular sounds and the vestibular sounds. All right. And they should be even on both sides. If not, then there's a problem with one lung or the other. On the back, we have 9 or 10 9 areas we want to listen to. And here again, we start above the shoulder blades and move down through the shoulder blades and then across the back. Okay. And then wide out here because you have a lobe down there. All right. But you're basically staying within the rib cage. Okay, so now we've listened to the heart and the lungs. We've looked at the head. Basically, I don't want to do this. I want to do abdomen because that's next in line, right? It's going down. Your abdomen, we're looking for bowel sounds in all 4 quadrants. And as like I said before, bowel sounds are bubbly, gurgly sounds. And normally you're going to hear 5 to 30 sounds a minute. 5 to 30 sounds a minute. And we're on page 388 here now. Okay. We're going to go in a clockwise direction, starting in the lower right lobe, then move up to the upper right lobe or area quadrant, and then the upper left quadrant and the lower left quadrant. We're basically following the pathway of your large intestine. You should hear sounds in all 4 of those quadrants. And they should be even. If you're hearing 20 sounds in the lower right quadrant, you should be hearing 20 sounds in the upper left quadrant, okay? So normal is 5 to 30 sounds a minute. If it is hypoactive, how many sounds a minute do you think you're going to hear?
1.
1 will work, yes, less than 5. Okay. If it is hyperactive, how many sounds are you going to hear?
31 and above.
31 and more. Okay. So if I have a patient with hypoactive bowel sounds, that means things aren't moving very well. What kind of condition do you expect to see?
Congestion, like, what's that called?
What's it called when you can't poop?
Constipation.
Constipated.
Constipation, yes. So low, slow bowel sounds usually lead to constipation. Conversely, hyperactive bowel sounds are going to lead to what?
Diarrhea.
Area.
Diarrhea, yes. So you have to be, listening for both of those. Then the other thing when we're doing our abdomen, we're going to listen before we palpate on the abdomen. That's the only body system you're going to listen before you palpate. You're going to inspect, listen, and then palpate. Because we don't want to start false bowel sounds by pushing on the gut. All right, but when we do palpate, we're looking for distension and tenderness.
What's it called? Palpate.
Palpate is when we use our fingers to push down.
Oh, okay.
Okay. And then we're going to look at the skin and the extremities. Okay. We're going to inspect the skin for rashes and lesions and dry skin and signs of dehydration or edema. So dehydration, when you're checking for dehydration, if you pinch at your collarbone, okay, and then let it go, it should snap back. Your skin should snap back. If the skin remains tented, that means we have dehydration. All right. Edema is that swelling that you find in the hands and the feet, sometimes on the face. All right. That means the heart's not pumping very well, or we have some kidney issues. But yes, the swelling is excess fluid. So tenting, when you check the turgor, is dehydration. Swelling is excess fluid. And then you're also going to check your peripheral pulses when you're checking your extremities. We're checking our extremities to see if they move in the correct manner. Do they have range of motion? Is there any pain? And then we're going to check all our peripheral pulses. And then finally, we're going to review the genitalia, anus, and rectum, and only unless there's an issue with these areas do we have to actually look at them, okay? They can be assessed when you're bathing your patient or performing pericare, but you always ask your patient if they have any issues with urination or bowel movements or something like that, hemorrhoids. So there are some systematic ways to perform an assessment, and we did that head to toe. That's one. Another way is to do the RN's HOPE assessment. So this is your, it's on page 389. It's the basic needs assessment, okay? And so we're looking at rest and activity, nutrition, safety, hygiene, oxygenation, psychosocial, and elimination. So you can remember the acronym RN's HOPE to determine, you know, to do that in order. Okay. And then finally, we have our focus assessment. These are brief examinations. We don't need to do a head to toe every day. This is just checking their general well-being. So we're going to listen to their lungs, listen to their heart, check their abdomen, check their surgery site, check what our problems are, okay? So question number one, you have a patient who's been receiving dialysis for several months with a dialysis shunt in her left arm. When taking vital signs on her patient, what is it important for her to remember?
Blood pressure should only be taken in the right arm.
Right,
I mean, yeah, great.
right. We can't, number three, we can't take it in the left arm because that's where her shunt is and we don't want to mess with that shunt. Okay. On auscultation, Maggie notices her patient has rhonchi in her lungs bilaterally. How can those best be described? Yes, Shamari, it is. Whichever Shamari that is. Yes. So the answer is 2. Coarse, low-pitched, rattling sounds caused by secretion in the larger air passages. Okay. Question number 3, the patient says they have ringing in their ears. Who knows what that's called?
Tinnitus.
Tinnitus, yes, very good. So guys, on page 379, there's vocabulary specifically to a physical assessment. These are words that you need to put in your nursing vocabulary. So put them on flashcards, you know, memorize them.
Can you repeat what you said?
Page 379, box 22.5. This is vocabulary that needs to enter your nursing vocabulary. Okay, we need to get this into your nursing vocabulary. And tinnitus is one of those words. That's where that word came from. Okay. But also things like lethargy and orientation and petechiae are very important words for you to know. Okay. So your assessment of basic needs, we already talked about. We can use RN's HOPE to remember how to do that. Rest, nutrition, safety, hygiene, oxygenation, psychosocial, and elimination. We can always do patient education, okay? You can always educate your patient as part of your nursing practice, okay? So some of the things that you can include could be regular physical exams, recommended diagnostic testing, you know, like colonoscopies and mammograms and pap smears, the need for immunizations, the warning signs of cancer, especially skin cancer, when to notify their primary provider. Yes, the slides are all in week 4 reading. Sometimes you are assisting in these examinations, and so you have to know how to position your patient and drape them properly. We want to begin with them seated. We want to put a drape over their lap and their legs. Generally, we have them take their clothes off or put on a paper gown, okay? We want them laying down and the drape is pulled up over the upper body so your chest or your abdomen can be exposed. Now, here are some specific positions, and we're going to learn about positions next week, but one of them is the lithotomy position. And this is the position that they use for gynecological examinations, where you're laying on your back with your feet in the stirrups, okay? The knee chest position is you're on your stomach, and then you bring your knees up to your chest, and so your butt's up in the air. So it makes it easier for them to examine. Your lateral or Sims position is the side lying position. Sims is you're a little more prone than side lying. It's a good position for suppositories and enemas and rectal examinations. And then prone means we're lying on our stomach. Okay, supine means we're lying on our back, and prone means you're lying on your stomach. Always make sure that they empty their bladder before a physical exam, because you're going to be poking and prodding on their belly and you may cause some incontinence. Prepare the exam table, get all the necessary equipment ready for the provider. Okay, so if we're doing a pelvic exam, then we need the pap smear stuff and things like that. We're going to need gloves and lubricant. You know, if we're going to be checking the interior of the eye, we're going to need an ophthalmoscope available. We're going to need an otoscope to listen to the look in their ears. And then finally, we're going to evaluate how well we did with our physical assessment. Okay, this is not evaluating the patient. This is evaluating you. Okay, so did we get all the information we needed to get? Are there any holes in the database we need to go back and fill in? All right, these are the kind of things you're going to ask yourself when you're done doing a physical exam or assisting in a physical examination. So a systematic way to perform an assessment is to use the acronym RN's HOPE, which letter is correctly defined. I heard it too. Everybody agree with that?
Yeah.
Okay. So, very good. So if you look on page 391, box 22-7, this is the head to toe assessment you're going to do every shift on your patients. This is your focus assessment. This is basically what we're going to be doing for your physical assessment, okay? So you're going to be looking at your initial observation of skin color, appearance, ease of respiration, how the patient's feeling, and then check our neurosystem, ability to respond to questions, communicate, level of consciousness, presence of JVD. Who knows what JVD is? Jugular vein, which is in your neck, distension. So if somebody has high blood pressure or they have a lot of fluid on board, you're going to see this vein sticking out, okay? Sometimes when people get all excited or they're agitated, you'll see that vein sticking out also. We're going to check their vital signs. We're going to check for pain. Then we're going to listen to their heart and their lungs, their abdomen, their extremities, and then check any equipment they have going. If they have any tubes or equipment attached to the patient, we need to check it, make sure it's functioning. We need to make sure that there's no signs of infection or anything going on, and then their assessment of needs. But that is your basic shift head to toe assessment. Okay, any questions? Okay, you're coming to campus for 1 o'clock if you're coming to lab today. The rest of you I'll see at 10 o'clock tomorrow morning. Remember, you need to be here a little early so you can pick up your lab bag. Okay,
Yeah, I have
so
a question. So, they were calling for this class. Like, are you still posting on Canva?
say
They
again.
were calling for the class, that for the lecture. Are you still posting on Canva? They were calling.
They saying the recording of the class, are you still gonna
Oh,
post
yeah,
this on
yeah,
Canvas?
I will post the recording. Yes, I'm sorry. Okay, we are having lab this afternoon, not lecture. Okay, so you need to come in, you need to get your lab bag, bring your math book. We may have time to do some math, and your Perry and Potter clinical skills book. Make sure your nails are cut, nail polish is off, your hair is pulled back, you're in your uniforms with white shoes preferably. Okay, so everything in your lab bag, yes, bring it all.
What
We
was the
already
book you
have-
said?
I said the clinical skills book.
Is it both sets or is it just one?
Professor Novak, you said tomorrow at 10 o'clock. Do you mean Thursday at 10 o'clock?
Thursday at 10 o'clock. I'm sorry. I have
Okay,
another
just
lab tomorrow.
okay,
Okay,
just
so
making
this book,
sure.
the clinical skills book, all right, Perry and Potter, and your math book.
So you don't have to bring the one that like explains the
No.
figures? Okay.
No. Okay. When you come, you're going to come to the south entrance, and then Miss Kaplan will be down there at 12:30 to start letting you guys in. You have to pass the health screening, and then you can come upstairs. Okay. Look forward to seeing you all this week on campus. I love it when I can see you in person. So, and it's going to be a fun lab because there's lots and lots of stuff to do. So I will see you all at 1. I'll see those of you coming today at 1 o'clock, those of you coming on Thursday at 10 a.m. Okay? Have a good day. Be safe coming to school. And I'll see
Thank
you
you.
later.
Thank you. Thank you.
You're welcome.